Hi, everyone. So today, let's talk about hydrocephalus. What is hydrocephalus? What are the causes? What is the pathophysiology? How does the hydrocephalus look on neuroimaging? And what are the common terminologies used in and around hydrocephalus is what we will look at in this video. So the term hydrocephalus is derived from a Greek word where hydro means water and cephale means head. So in layman terms, it is accumulation of water in the head. Medically, it's accumulation of CSF, which is the cerebrospinal fluid within the ventricles of the brain. Now, basically, when there's excess CSF, an excess of anything can be either because of increased production, decreased removal, or an obstruction to the flow in the pathway. So similarly, excessive accumulation of CSF within the ventricles can happen either because of increased production of CSF, or if there's an obstruction to the flow of CSF along the pathway, or if there's decreased removal or resorption of CSF. All of this causes hydrocephalus. So before we look more into detail about hydrocephalus, let's quickly revise the normal circulation of CSF in the brain. So the cerebrospinal fluid is produced by the lateral ventricles, in the lateral ventricles by the choroid plexus. So that's the site of production. Once it is produced, so we look at this sagittal section of the brain, the gray colored structure in the background that I'm pointing at are the lateral ventricles, and that is where the production of CSF happens. The CSF then moves down through the foramen of Monro, which is this little structure here, to enter the third ventricle. From the third ventricle, it moves down through the aqueduct of Sylvius, which is this little slit of foramen, into the fourth ventricle, which is this triangular structure. From the fourth ventricle, the CSF exits through either the foramen of Loschka or Magendie to enter the cisterna magna. Once the CSF has left the fourth ventricle, it will then get resorbed by the arachnoid granulations, which are these little structures jutting out. And the resorbed CSF then enters the sagittal sinus to be absorbed into the venous circulation. So production of CSF by the choroid plexus of the lateral ventricles through the foramen of Monro into the third ventricle, aqueduct of Sylvius into the fourth ventricle, out by the foramen of Loschka and Magendie to enter the cisterna magna, resorption by the arachnoid granulations to eventually enter the venous circulation. So this is what a normal CSF flow looks like. If we compare these two images where this is a diagrammatic representation of the sagittal section of the brain, if we see the same thing on an MRI, this is what it looks like. So the gray or the black colored, not the gray, what I'm trying to say is the black colored structure is basically water or CSF. So this is the lateral ventricle. This is the third ventricle. There will be a foramen of Monro here. It moves down into the fourth ventricle through the aqueduct of Sylvius, and it exits the fourth ventricle through this midline foramen to eventually get absorbed into the venous drainage. So it's very important for us to know what a normal brain sagittal section looks on a neuroimaging, so that then when we look at what happens in hydrocephalus, we can make out the stark difference. Now, when I was a med student, I always got confused between a CT scan and an MRI of the brain. It was difficult to identify which one is the CT and which one is an MRI. And that's often the first thing that you have to do when you have a scan in your hand. So let's quickly look at the basics of how do you differentiate if it's a CT scan versus an MRI. So on the left is an image of the CT. So if you can see the skull or the bony structure is predominantly dark, is predominantly bright white in color. Whereas on the right, these are the two different sequences of MRI, T1 and FLAIR. The bone is not as prominent as it is in the CT. So basically a CT scan is used to see fractures or any skull pathologies or acute conditions like bleeding. Whereas if you want to study more about the brain tissue, the soft matter, then MRI is a better imaging modality. So if it's bleeding, fracture, or any acute pathologies, then CT is the preferred option. If you want to look at soft tissue, brain matter diseases, whether it's multiple sclerosis, whether it's the presence of any tumors, cysts, autoimmune conditions, or yeah, anything that involves more of the brain matter, then definitely MRI is a better imaging modality. Other than these two differences, we all know that CT is cheaper, it takes lesser time. Of course, it exposes the patient to radiation, whereas MRI is a more expensive imaging modality. It takes longer, and that's why it's more difficult to get an MRI brain done in a child. So that is another struggle in pediatrics. And of course, MRI, yeah, it takes longer, but it is safe because there is no exposure to any radiation. So those are the basic differences between a CT brain and an MRI, and the indications as to when would you want to do a CT versus an MRI depending on the clinical scenario. Again, if we look at an MRI, there are different sequences like T1, T2, flare, etc. The stark difference between that is if you look at the T2 weighted MRI sequence, the CSF appears white. So there's this mnemonic which says World War II, WW2. So that's water is white on T2. So that's water is the CSF, white and 2. So World War II. I don't know where it's come from, but that's how I remember it. So T2 is very easy to identify because the CSF and ventricles will appear white. Now, how do you differentiate T1 versus flare? So both of them will have black colored ventricles. So, that's not the way to differentiate. But what is different is that if you look at the white matter in a T1 weighted sequence, it appears bright in color versus the same white matter on a flare appears darker gray. So that is one difference between a T1 weighted MRI sequence versus a flare. There are several other sequences. There can be a T2 flare, etc., which is again confusing because T2 will appear white in CSF with a flare component. I'm not really going into the details of all of that, but this is like the basic difference between a T1, T2, and a flare imaging sequence, and how do you identify if the sequence is one of these. So moving ahead, going to the neuroimaging in different sections. So this is a coronal section of the brain on an MRI, where the green arrows point to the lateral ventricle. So this is the frontal horn, and this is the occipital horn of the lateral ventricle. And the slit-like structure in the center is the third ventricle. So this is what ventricles will normally look like on a coronal section of the brain on an MRI. We know that all structures of the brain are not visualized on one section. So we need to take sections at different levels to be able to see different structures. So a level or a section a little lower down will show the fourth ventricle, and this is what a normal fourth ventricle looks like. So this is how ventricles will appear on a coronal section of the brain on an MRI. Now, moving ahead, we already saw this diagram before where we could appreciate the lateral ventricles, the aqueductus sylvis, third and fourth ventricle, now which is a normal MRI. So keeping this in mind, if we look at the image on the right, we can see that there's gross dilatation of the lateral ventricle and the third ventricle, but the fourth ventricle looks normally sized. That means there is dilatation of the proximal two ventricles, but the fourth ventricle is normal. This is what we see in a case of aqueductal stenosis. So there is stenosis in the aqueductus sylvis, which is causing an obstruction to the flow of CSF, which is resulting in accumulation of CSF causing dilatation of the proximal two ventricles, which is the lateral and the third ventricle. But the fourth ventricle looks normal. And so this is a comparison of what a normal versus a hydrocephalus MRI looks like. And we're able to delineate the site of pathology on the basis of the ventricles being dilated, and the ventricles being dilated will give us exactly the site of what the obstruction or what the pathology is. And congenital aqueductal stenosis is the most common cause of like congenital hydrocephalus, and this is what it will look like on a neuroimaging. If we look at this image, now this is again a CT scan, we can see that the skull appears bright, prominent, and well demarcated. So there's dilatation of the lateral ventricles. The third ventricle, which normally appears like a slit-like structure, also is dilated. But the fourth ventricle looks normally sized, and that is why this is again a case of aqueductal stenosis. So again, this is how you identify the site of pathology depending on the ventricles that are dilated. Now, what is the pathology of hydrocephalus? So what happens is that once the ventricles dilate, they disrupt the ependymal lining across the ventricles. Now, when there's disruption of this lining, it allows the CSF to move out of the ventricles into the surrounding brain tissue. Now, this in turn helps in decompressing the ventricles, but due to the accumulation and pressure of CSF in the surrounding white matter of the brain, it results in edema, ischemia, eventually atrophy of the white matter. So as the hydrocephalus keeps progressing, there's edema and ischemia in the periventricular region, eventually leading to atrophy. And we know that the white matter is what travels by the periventricular region, which is your tracts. And that is why involvement of these tracts in hydrocephalus results in the CNS manifestations that we see. So what is the pathogenesis of hydrocephalus? Why does hydrocephalus happen? So like we saw, it's either because of increased production, an obstruction to flow, or decreased drainage of CSF. Increased production happens when there's a choroid plexus papilloma, which is the site of production of the CSF within the lateral ventricles, or if there's an obstruction to the flow anywhere within the ventricular system, either because of post-inflammatory or post-hemorrhagic changes, or if there's a congenital stenosis or atresia of any of the foramen along the pathway of CSF, or if there's decreased absorption by the arachnoid granulations, either because of hemorrhage or inflammation. So these are the common three categories that can lead to hydrocephalus. If we look at the causes more in detail, we have congenital and acquired causes. Congenital could be because of Torch group of infections or Zika virus. Malformations like Arnold-Chiari type 1 and 2, Dandy-Walker, arteriovenous malformations of the brain like the vein of Galen malformation, cysts, and cranial defects like craniosynostosis, achondroplasia, osteopetrosis, and others. Moving to the acquired causes, again, infections, mostly meningitis, either bacterial or tuberculosis. Post-hemorrhagic, whether it's an interventricular or an intercerebral hemorrhage. Choroid plexus papilloma. Space-occupying lesions like tumors, most commonly posterior fossa tumors in kids, like medulloblastoma, or others like ependymoma and astrocytoma. And interestingly, even hypervitaminosis A results in excessive production of CSF by disrupting the blood-brain barrier, which can again lead to hydrocephalus. Now, we saw Arnold-Chiari and Dandy-Walker. I mentioned these two as congenital causes of hydrocephalus. So what are these two? If you look at the image on the left, the A diagram, the yellow line refers to the level of the foramen magnum. And if we see the cerebellar tonsils lie above the level of the foramen magnum. On the right, the B diagram shows that the cerebellar tonsils are below the level of foramen magnum. And that is what can cause an obstruction to flow of CSF. And this is what we see in Arnold-Chiari type 1, where the cerebellar tonsils have shifted downwards and displaced downwards below the level of foramen magnum, which can cause hydrocephalus. Arnold-Chiari type 2 will have this along with the presence of a meningocele or a meningomyelocele. And both of these can lead to accumulation of CSF by obstruction to the flow. Now, if we see this diagram, it's a Dandy-Walker syndrome where there's a large cerebrospinal fluid cyst located in the posterior fossa, this bright white big structure, along with hypoplasia of the ventricle. So these two wings labeled C are the hypoplastic cerebellar hemispheres with a winged appearance. That's what it's called. So this is, again, a huge cyst causing obstruction to the flow of CSF, which can again result in hydrocephalus. So now that we've seen the cause of hydrocephalus, let's look at common terminologies that are commonly used but mean different things. So what do we mean by macrocephaly? Macrocephaly refers to a head circumference measuring more than +2 standard deviations above mean, or more than 97th percentile as compared to normal population of that age and sex. So a large head, basically, where the head circumference is more than +2 standard deviations, is what is defined as macrocephaly. The cause of macrocephaly can be because of anything that is big when you look at a head. So it could either be a big brain parenchyma, big skull, excess CSF like hydrocephalus, or increase in the blood volume. So if you look at detail at cause of macrocephaly, it could be either because of a big skull, like in hemolytic anemias. We commonly see that in thalassemia when they have extramedullary hematopoiesis, or other causes like osteopetrosis, achondroplasia. If there's accumulation of fluid in the subdural space because of an effusion or hematoma, accumulation of CSF in ventricles, hydrocephalus, megalencephaly, where there's increase in the brain parenchyma, seen in certain syndromes like Soto's, again can cause increase in the size of the head, and other causes like intracranial tumors, cysts, and genetic conditions like mucopolysaccharidosis, Tay-Sachs, etc. So these are the common causes of macrocephaly. So again, this question can be asked to you in your viva when you have a case of hydrocephalus, and what is the definition and what are the causes. So remember, other than hydrocephalus, you also have other causes of macrocephaly. Now, just ending this with one last clinical scenario where you have a child who presents to you for a well-child clinic, asymptomatic, he's just coming for routine immunization. But when you do an anthropometry and you measure the head, by definition, it falls under the category of macrocephaly. So let's say when you do a head circumference measurement and you plot it on the growth charts, it falls at 2.5 standard deviations above mean. But on history, there is no CNS symptoms, no CNS signs. Your CNS examination is normal, reflexes are normal, the child is developmentally normal, no other significant family history. So in that child, this is a case of an asymptomatic macrocephaly. So what do you do next? It's very important that instead of like panicking the parents and thinking of all that can go wrong with the child, the first thing in a case of asymptomatic macrocephaly is to measure the head circumference of the parents, because there is a thing like familial megalencephaly, where the family members have generally large heads, and that causes mild macrocephaly. But if you track this child over time, you will realize that he's following the same growth curve, although above the 97th percentile, but there is no significant increase in the size of the head from there. And of course, there are no signs and symptoms that worry or any developmental delay. So in a case of asymptomatic macrocephaly, the first thing to do is measure the head circumference of the parents, and then obviously keep a close eye on this child. So that basically ends the discussion of basics of hydrocephalus. And the next video will be a discussion of a case presentation where we look at the history taking, examinations, investigations, treatment, and all other viva questions if you have a case of hydrocephalus. So stay tuned and see you soon. Thank you.